Good morning, everyone. We'll be starting in a few minutes, so if we could get everybody to kind of start coming in and finding your seats, we'd appreciate it. Thanks. Okay, good morning. If we got everyone take their seats, please. My name is John Klass, and I'm the AMSUS Deputy Executive Director. We'd like to welcome everyone to the Gaylord and officially open the AMSUS Annual Continuing Education Meeting. We are absolutely pleased that you all could come with us today. There's always the guy that's got to do the housekeeping stuff, and that's me. So, first of all, if you have your cell phones with you, please put them on silence. We will have some early bird sessions that will start at about 7 o'clock each morning, the rest of the week. Some really good, interesting topics. And for those that want to come to the early session, we will have coffee out here available from 6:30 to 7 for the rest of the week. So please come in and listen to the speakers, some real interesting stuff. Full paying registrants should have received a voucher for lunch in the exhibit hall for today and tomorrow. So if you paid and you didn't get that, then stop by registration. In the exhibit hall, the Air Force is proud to exhibit their new transportation isolation system, along with many other innovative products and displays. So please take the time to visit and talk with a lot of our exhibitors. There's a lot of good information, a lot of good things that I think you'll find of interest. A tradition, of course, we know in the military is to have a coin. We will have annual meeting coins available in the exhibit hall. I'm not going to tell you where they are right now, so I'm going to tell you got to go in there and visit everything and find them. So if you'd please stand for the arrival of the official party, and remain standing for the presentation of the colors, playing of the national anthem, and the invocation. So our official party is Major General Joseph Caravallo, we have Rear Admiral Sylvia Trent Adams, who I believe is on her way, so we will leave a seat for her. Lieutenant General Nadja West. Vice Admiral Forrest Faison. Lieutenant General Mark Ediger. Congressman Joe Heck. Dr. Karen Geis. And I believe stuck in traffic is Vice Admiral Raquel Bono, who should be here in a little bit. We have Karen Malabranch. Dr. Richard Thomas. Oh, I guess is going to be on his way. Oh, there he is. And last but not least, Vice Admiral Mike Cowan, AMSUS Executive Director. Color Guard, advance the colors. Color Guard, retire the colors. We want to thank the Air Force Color Guard for the presentation of the colors. And now our invocation. Lord, we come to you with thankful hearts for all the blessings you have given us. Our hearts are full of the thankfulness to those who serve our countries in the uniformed services. Father, we are reminded that our soldiers fight many personal battles, and we ask that today you would intervene in their lives and help each one individually. We know that there are times when each one suffers from loneliness, homesickness, exhaustion, sadness, fear, and a myriad of other difficulties. We ask you come to each one and ease their personal challenges and give each one renewed hope and cheer. We ask that you would put your hand of blessing on all the men and women who work tirelessly to bring your healing to the sick and injured. We pray you bless this assembly as we learn from one another to improve our skills, but most of all, we ask your help ensuring our actions are guided by kindness and compassion. Amen. Please be seated. At this time, it's my honor to introduce Vice Admiral Mike Cowan. Dr. Cowan was the Navy Surgeon General from 2001 to 2004, and for the past 5 years has been the AMSUS Fearless Leader.
Good morning, everyone. Thank you for coming here. As many of you know, this is AMSUS's 125th anniversary. We're proud of the meeting we're hosting today. I'm proud to see so many of you found the time to come and join us. I want to welcome all the flags, general officers, VIPs, our international colleagues from the multiple agencies that are represented here. I will not try to name names because we only have a week. So I don't want to go down that pathway, but thank you for being here, each and every one of you. We have a very busy week, and we have lots of things that we want to try to accomplish. The prime directive in all this, for those of you Star Trek fans, the prime directive is enjoy yourselves. Look, we came to get scientific updates on areas of interest. We came to hear our federal leaderships talk about who they are and where they're going, why they fight, how they work together. We have a wonderful exhibit hall where the latest and the greatest of the technologies and the products of the private sector are being shown. We have poster demonstration sessions that are being put on by the subject matter experts of the scientific world. We have wound care, hands-on stations. And last but not least is the opportunity for professional network and relationship building that's unrivaled anywhere else. Former Undersecretary of the VA once told me, this is the only place I can go see my peers in uniform and talk to them about professional things without having some economic paper in the middle that we're arguing over money. This is the place where we come to be the international professionals that we are, and to enjoy one another. We also have a book signing by Mary Roach down in the exhibit hall. That will be in the area of the center of the exhibit hall where AMSUS has its hospitality booth. So there's two things happening there. One is there are nice couches that you can sit and rest your weary feet and chat with your colleagues. And second, Ms. Roach is the author of Grunt, The Curious Science of Humans at War, which is a New York Times bestseller right now, and she'll be autographing books. I've read the book. I highly recommend it. Our educational tracks have something for everyone, and the industrious among you can get 20-plus hours of CE. And that's all Category 1 CE, And that's in pretty much whatever category you need your Category 1 CE in. So this is an opportunity to rack those hours up. And they are really on the important topics of the day. Anybody who has so much as scanned through the sessions recognizes that if it's a hot issue for American and federal medicine, it's somebody's here talking about it, and that somebody is the subject matter expert on it. A little navigation guidance. First of all, let me introduce the staff. Would the AMSUS staff please stand up, and if you're up, wave your hand. They're mostly over in the corner over there. They will be everywhere throughout the venue. They wear lanyards that have red bling on them, so you can kind of recognize, you'll learn their faces anyway. The brochure and registration desk is always available. But most important, check the plasma screens every day. Because although we have a plan, as anybody that has ever worn a uniform knows, no plan survives the first contact with the enemy. And the enemy in this case is the contingencies of late plane, change of administration, people get sick, rooms break down, and so we have a plan, but I don't think we've ever had a day that plan didn't change in some way. So when you come in, check those plasma screens, they'll give you all the information you need. The couple additional announcements. The AMSUS business meeting will be right here on Wednesday morning at the close of the plenary session. Those of you who are members, those of you who would want to be members or might be thinking about it, or those of you who just have an interest in the business of AMSUS, we'll ask you to stay after the plenary leaves, and we'll have a short business meeting. It's also not all work. There's a reception and poster session, 16:30 to 18:30 today in the exhibit hall. I highly recommend that. The posters are of tremendous quality, and as well as the exhibits. And the awards ceremony on Thursday is at 18:30. The recommended uniform is business or black tie optional, and for military, mess dress optional. And I highly recommend that those of you who have served in the past wear your uniform if you're comfortable doing that. If not, put your ribbons on, your campaign ribbons, because we're here to honor the best and brightest performances of individuals and organizations all across healthcare, and to see them being supported by those who have gone before, I think is very important. So please wear your uniform if you so feel inclined to do so. AMSUS, next topic. AMSUS is always looking into the future. Military medicine has changed, VA medicine has changed, medicine has changed, and as we have become increasingly dependent on and interdependent on one another, AMSUS is looking to be more of a 21st century AMSUS. As a part of the process to do that, we have created an executive advisory board of private sector organizations, private sector companies, who are going to help us refine and forward thought leadership and intellectual property for the advancement of federal health. These are sponsors who are also involved and engaged and have committed the time and the efforts and the horsepower of their organizations to be leaders in the advancement of federal health care. And several of them are here. I would like the representatives for LMI, HealthNet, Cognosante, United Healthcare, BiLight Professional Services, the TLI Foundation, Henry Jackson Foundation, Northrop Grumman, and Humana. If you would just stand up and wave your hand and let the folks know who you are. Please, when you get a chance to seek these folks out and meet them, I think you'll find terrific leaders and get a feeling for the future of AMSUS. Now I'm going to shift gears again, and during the registration process, we asked you for a voluntary donation to the USO. Many of you responded. And I would like to ask Pamela Horton, who is the Director of Warrior and Family Centers at Metropolitan Washington, Baltimore, USO, to come forward. And I would like to give her a check on behalf of the members and the attendees. The check is for, there's no check. Because we're not done collecting, the money is still coming in. We know that it's in excess of $2,000, but money is still coming in. And the opportunity to give is still open if you would drop by the registration desk anytime during the meeting and make a donation to the USO, even just a few bucks. That will really help, and we will add it onto the check. So Pamela, you have my promise. There will be a check. This is just an empty envelope. Thanks.
Thank you so much. I appreciate it. And also just the exposure. So thank you.
Also want to give a quick shout out to the sponsors of this meeting. Like the dignitaries and VIPs here, there's really too many to mention because I want to get off the stage and let you listen to who you really want to listen to, our president and our guest speakers. But for all of the sponsors, again, who you see on the plasma screens that you're going to be paying attention to on a daily basis, right? Those are the guys. If you see any of them or meet any of them, help us thank them because it's a lot less expensive to attend because of their sponsorship. Okay. It's now my honor to present Lieutenant General Mark Ediger, who's the Surgeon General of the Air Force, and is this year's honorary president of AMSUS. This cycles among the various service agencies. General Ediger is a native of Springfield, Missouri, who entered the Air Force in 1985 and has served, among many other things, as the aerospace medicine consultant to the Air Force SG. He's commanded at least 2 medical groups and has been the command surgeon for 3 major commands, multiple deployments, and a good friend of AMSUS. Mark, thank you for being here. It's all yours.
Thank you, Mike. Well, good morning. It was a special privilege for us to coordinate the contributions of many to put together the agenda for this very important gathering. And so we had a lot of excellent contributions from Army, Navy, Air Force, Veterans Administration, the Defense Health Agency, and the Office of the Assistant Secretary of Defense for Health Affairs in putting together what we think is an excellent and very productive agenda for this week's gathering. We've really been looking forward to this. AMSUS for us encompasses the full aspect of medical support to those serving our nations and the members of the armed forces. And it is a rare opportunity to convene expertise that's truly focused on the health and performance of those who serve and their families, and also in terms of sustaining the health of those who have served, our veterans, and to do so in an international venue with all of our international colleagues contributing greatly, as they always do at this gathering. It is very important, we know, in military medicine that we be a learning system. That's how we improve, is really by applying the scientific rigor and gathering the data, looking at the data, determining what the data tells us, and then making the adjustments in our practices in support of both combat and disaster response to improve outcomes and save lives. We all recognize that the journal Military Medicine, as published by AMSUS, in my opinion, has become the foremost journal focused on support to military operations. And this meeting is an important complement to that, as an opportunity to get together face-to-face, share research, discuss issues, share operational experiences, and determine how together we can move forward in supporting the important missions that we are all responsible for. Throughout the history of military medicine, we've periodically encountered forks in the road, crossroads, if you will, and I think we're at one of those now. What may be interesting about the crossroad we're at now is it's not just a simple intersection. I think it's like that part of Washington called Seven Corners, where you've got multiple roads coming together simultaneously. We know that in the past 15 years, we've made historic advancements in combat casualty care. And as we've done that largely by being a learning system through establishment of the Joint Trauma System and leveraging the knowledge that that has generated for us. In looking at that data, we recognize that there are more opportunities ahead to save lives and improve outcomes. We recognize that those opportunities exist in prevention. They also exist in terms of point of injury care and forward resuscitative care. So certainly great opportunities to move forward together and to make a very positive difference. At the same time, we know that the current combat operations we support are requiring some changes in the way we provide medical support, and that there is greater requests from the warfighters for agile pre-hospital trauma resuscitation and damage control surgery. And so that's required all of us to work together with the Joint Staff Surgeon to determine how we can meet that requirement going forward. At the same time, we know it's important that we not be prepared for the current war or for the past wars, but actually look forward. And we recognize there are security threats in other parts of the world that would present very different challenges for us in terms of medical support, as reflected in the National Military Strategy. We know on the medical side that there are exploding really opportunities to apply innovative diagnostics and therapeutics in the operational realm. Our clinicians are doing this today in the field. And we know that operational realm includes all the way from point of injury to forward resuscitative care, to the field hospital, to the theater hospital, all the way through the aeromedical evacuation system to definitive care. There are opportunities in there to take advanced techniques into that realm. We know that nationally there is ongoing concern about the consequence, the health consequence of serving in the military, and strong support for our efforts to prevent those consequences, and when they do occur, to effectively manage and treat them. We know that the operations tempo worldwide is becoming more diverse. Things are not slowing down. Thankfully, we're moving and treating fewer battle casualties today, but we know that if you look across the realm of our military's engagement around the world, both jointly and as a coalition, the tempo is quite high and not slowing at all. At the same time, we know that resources are a concern. And we know that nationally there's concern about the percentage of the DoD budget that is dedicated to health support and the possibility of that growing upwards towards 10%. So it is a crossroads, but with every crossroad presents an opportunity, and so the path we pick to go forward is an opportunity to pick the right path that will give us the capability that will be needed into the future, and truly put us in a situation to support the mission and those who serve years into the future. So we know that in doing this, we're going to have to think through some changes. We've been tightening the integration of the U.S. military health system. We know that we're going to need to think through, particularly in the Air Force mission, the integration between the reserve component and the active component in terms of both the execution of the mission on the operational side, but also the military medical support. We know that there's going to need to be greater emphasis on operational alignment of all that we do, and we're going to need to apply rigor in assessing our priorities because of the constriction of the resources. In doing so, we'll need to consider all aspects of value in the health care we deliver, as well as the operational support. As part of the agenda for this week, you'll see high reliability. I think that's absolutely essential because that is a new way of applying our commitment to quality and safe care that extends not only in our clinics and hospitals, but into the operational realm. And so we think that is an essential part of our future capability. We also know that standardization of our clinical and population health processes going forward will be important to addressing both the outcome opportunities, but also the concerns about cost. So we have a great agenda this week. I think it's going to enable substantive exchanges of information, and we really look forward to the opportunity for the interaction this week. As the Air Force Surgeon General, I'll call special attention to the aeromedical evacuation displays and presentations that will occur this week, including the capability to move patients with high concern infectious disease. We're very grateful to the Air Mobility Command and their Command Surgeon, Brigadier General Lee Payne, for providing significant assets for display to give you an opportunity to see how those equipment sets work and also to hear the presentations. So most of all, thank you for your participation this week. This is a very important venue for us moving forward strategically, knowing that we are at a crossroads, and the exchanges that occur this week and the continued interaction with AMSUS will certainly serve us well. So at this point, it is my privilege to introduce Congressman Joe Heck. Congressman Heck has served in Congress since 2010. He serves on the Education and Workforce Committee and the Armed Services Committee, where he is chairman of the Military Personnel Subcommittee. He is a member of the House Permanent Committee on Intelligence and chairs the Subcommittee on Department of Defense Intelligence and Overhead Architecture. A longtime AMSUS member and a Brigadier General in the U.S. Army Reserves, he was called to active duty 3 times, including a deployment to Iraq in support of Operation Iraqi Freedom. Congressman Heck is currently serving in his role as a Reserve Brigadier General in the U.S. Army Reserve as the Deputy Joint Staff Surgeon. He is a 1984 graduate of the Pennsylvania State University with a degree in health education. He received his medical degree from the Philadelphia College of Osteopathic Medicine in 1988 and completed a residency in emergency medicine at the Albert Einstein Medical Center in 1992. In July 2006, he graduated from the U.S. Army War College, earning a Master's of Strategic Studies. Ladies and gentlemen, Congressman Heck.
Thanks, sir. Thank you, General Ediger, General Officers, Flag Officers, Admiral Cowan, Madam Secretary, President Thomas, distinguished attendees. Thank you very much for the opportunity to be here and speak with you this morning a little bit about federal health care and raising the bar. It's truly my honor to have this chance to come to talk to all of you who have dedicated your lives and your careers to caring for those who have borne the battle. And although we come from different services with varying backgrounds and perspectives, we are joined in our common bond to provide for those who seek care and to improve the health of the communities we serve. For me, that journey began in 1991 while completing my residency at the Albert Einstein Medical Center. I was thinking about joining the reserves. Desert Shield had just turned into Desert Storm. And so my goal was to actually join the Navy as a reservist, immediately volunteer for duty to go support Marine Corps units. Because as a kid growing up, I always wanted to be Marine, especially after watching the John Wayne epic Sands of Iwo Jima. I thought, I'm going to be a Marine someday. Well, made that call, didn't quite work out that way, and I'll talk more about that in a minute. But my thinking at the time was that if I was able to volunteer, deploy, and serve, that my service would be worth it if by being there as an emergency medicine doc, just one more soldier, sailor, airman, Marine made it home. If one more son or daughter, husband, wife, mother, father, was able to make it home because I was there as an emergency medicine doc, that my service would be worth it. And that thought remains the driving force behind my entire career in the Army Reserve. Now, that was also my first encounter as I was trying to get into the reserves with the seemingly slow pace at which the government operates and the bureaucracy involved with trying to get into the reserves, which goes back to my initial story. Remember, I said I wanted to be a Marine, but I spent my career in the Army. So what happened? Well, that day when Desert Shield turned into Desert Storm, I was actually working a shift in the emergency department at Albert Einstein. I said, I got to get me into this. So I go over to the phone book and I look and I said, this is what I'm going to do. I checked it out with my residency director. He said it would be okay if I left and then came back. And I saw the phone number for the Navy recruiter. So I called the recruiter and explained to him what I wanted to do. I'm a junior emergency medicine resident. I want to come into the Navy Reserve. I want to immediately volunteer for duty and go support ground troops with the Marine Corps. And I was getting this, well, I don't know if we can do that. I'm not sure we have a spot for that. We'd like to take you on active duty. And he kept going on and on, but just wasn't focused on what I wanted to do. And I said, no, I don't think I can do that. Thank you very much. Like, wow, now what do I do? going down the yellow pages. Army recruiter. So I called the Army recruiter, explained the same thing to him, what I wanted to do. And he said, well, where are you right now? So, well, I'm in the emergency department at Albert Einstein. He said, don't move, I'll be there in 15 minutes. Sure enough, 15 minutes later, this AMED recruiter shows up in the emergency department at Albert Einstein and starts giving me all this paperwork to fill out. And I thought, okay, I'm going to go into the Army Reserve. Now, fortunately, because of the speed and efficiency of our armed forces during Desert Storm, Desert Storm was over by the time I got the phone call from the AMED recruiter saying, hey, the Army's ready for you to take your oath. I thought, I just can't get a break. Like, well, now what do I do? So I spoke with him, and I said I tried to get some concessions out of him now to get me in. I said, you know, I really would like to be a flight surgeon. He said, okay, well, we'll get you in the flight surgeon school if you take your oath. And I said, good enough, signed on the dotted line, raised my right hand, 26 years later, still serving in the Army Reserve. Sorry, Admiral Faze, and I tried. Guys just wouldn't take me. So I've had the privilege over that time now to command those who work each day to improve the health and welfare of members of our uniformed services and their families, and I've had the opportunity, the privilege really, to care for the brave men and women who are willing to sacrifice their lives in defense of this nation. For me, there's no higher calling, really, than to want to serve, to care for those who nowadays volunteer to sign on that dotted line, raise their right hand to swear an oath, pick up a weapon, and go stand a post in some far-off land to protect and defend this nation, our liberties, and our democracy. Now, in 2011, my service took a different path when I was first elected to the House of Representatives. Given my background, wouldn't be hard to imagine what areas I would want to concentrate on. My goal was to try to make an impact on military and veterans health care. So I was selected to sit on the House Armed Services Committee in my first year, and then was also assigned to the Military Personnel Subcommittee, which has jurisdiction over health care issues, the committee that I now chair. And after spending my entire reserve career taking care of military personnel in primarily a reactive manner, and as a representative of a very large veterans population that's based in Las Vegas, I now had the opportunity to try to craft proactive policies aimed at having a meaningful impact on the lives of our service members and veterans. And this has been extremely rewarding work for me, and work that I plan to remain engaged in regardless of where my career path takes me. And I believe we can look back over the last several years and all agree that real progress has been made in increasing the ability and the quality of us to provide great health care for our men and women in uniform, veterans, families, and survivors. But the theme of this annual meeting is raising the bar, meaning we need to do even better than we are today. Where we are today is really just a starting point, not a finish line. We need to not rest on our laurels of what we've been able to accomplish, but look forward as to where we need to go to continue to try to provide the best quality health care services across the federal health care enterprise. And so what I'd like to do is spend a few minutes talking about two areas that I think require attention and areas where I've focused, and that's obviously on veterans health care and the DoD health care enterprise. Now, I know throughout the course of this meeting, you will hear from many experts and incumbents, some of whom are sitting up here today, that are working every day to raise the bar at both VA and DoD. And I would not be surprised if, or I probably should say when, they provide an assessment that's different than the one I will present, or disagree with my view of the way ahead. And I know this because we've had many discussions on some of these topics. To be clear, there is no disagreement on the ends. We all want to raise the bar. It's just that we may diverge on some of the ways and means to get to that end. Some of the ideas I will discuss are based on either currently pending or proposed legislation in Congress. But these remarks should not be seen as trying to telegraph what Congress will do. Because one thing I have learned during my 6 years in Congress is that no one, absolutely no one, can figure out in advance what Congress will or won't do. In fact, this year's NDAA hopefully will be on the floor this Friday, coming up for a conference report. That's still not set in stone, but we're hoping to get the NDAA passed for the 55th consecutive year this year. It's unfortunate that it's already been delayed past the beginning of the fiscal year. But really, my opinion, my discussion today is based on one military physician, soon-to-be former member of Congress, views on what should or could be done with the overall goal of better care for our servicemen and women, their families, our veterans, and survivors. So I'll begin with the VA healthcare system. First, let me state up front that all of the interactions that I have had with the men and women who serve our veterans at the VA demonstrate by and large that they are hardworking, caring people who want nothing more than to take care of those who so honorably served our country. A great many of them have served themselves. They chose as a career path, as many of us, a life of service to others, and for that, they should be commended. And the VA is dealing with extremely difficult challenges in caring for our former service members. From the demands associated with an aging veteran population, increased beneficiary load due to the expansion of Agent Orange presumptive diagnoses among Vietnam vets, the number of service members from the current conflicts who have survived grievous physical wounds or are suffering from the unseen wounds of war, our VA system is pushing its limits. But despite the new strains on the system and the challenges we face, we must raise the bar. And there are two areas that I think we should focus on, and those areas are customer service and actual access to care. And while the two certainly are related, we should take them each in turn, starting with customer service. Now, to be clear again, the VA is making tremendous strides in this area. According to testimony given by Secretary McDonald before the Senate, the VA has increased the number of veterans appointments by more than 1.2 million in FY15, completed over 96% of appointments within 30 days of clinically indicated or veterans' preferred date, instantly enrolled over 10,000 veterans online since the vets.gov website was revamped. And the Veterans Health Administration and Choice Program contractors created more than 12 million authorizations for veterans to receive care in the private sector. But it's not just about the number of appointment slots or the speed with which an appointment can be made. It is about the veterans, the customers' total experience. Here, variables like facility appearance and employee responsiveness are just as important in determining the veteran's overall satisfaction with his or her visit. And while it's not the only part of the solution, funding is a critical piece of the puzzle. Now, we have all lamented the impacts of sequestration since it was first passed, and the impact that it has had on the Department of Defense in dwindling budgets. But the VA has seen increases every year, every fiscal year, in discretionary spending. In fact, it's the only federal agency that has seen an increase in discretionary spending year over year, every fiscal year between 2012 and 2017. And I think that goes to the importance that members of Congress place on caring for our veterans. This will allow the VA to continue to implement quality programs to better train service staff and strengthen organizational culture. Improving the employee experience is vital to improving the veterans' experience. And this has to include moving from a rules, fear-based culture to a principle, values-based culture. With everything that has come out in the media over the last couple of years regarding the VA, it has become an even more fears-based, rules-based culture, and has had, I believe, a detrimental impact on the ability for the VA to overcome many of the challenges that it faces. So Congress has concentrated on providing more sticks, whether it's giving the VA the authority to actually fire bad actors within the agency or limiting senior executive service bonus pay, for example. I would like to see more carrots. I would like to see the opportunity to reward innovation and risk-taking, letting the individual who has the idea, who sits at the front desk, be able to bring that idea forward on how to make the system work better. It's what I have seen in my private sector experience as a healthcare facility administrator. There's no reason why we cannot adopt that same model to improve customer service across the federal healthcare enterprise. I believe, like Secretary McDonald when he said, you can't fire your way to excellence. You have to empower those on the front lines to be able to care for the individuals that walk through the door. But the VA does need to be a more agile, nimble organization that uses every tool in its toolbox to be able to affect those means. The other critical area that we must constantly strive to improve is actual access to care for our veterans. I can tell you that the overarching concern I hear when I talk to veterans is not about the quality of care they receive in the Veterans Administration. In fact, they will gladly say that the care that they receive is the best care that they have ever received. Their issue is the bureaucracy in getting the care. Whether it's wait times, lack of specialty providers, last-minute cancellations and rescheduling, those are the recurrent complaints that I've heard all around the country. If you solve that, which tends to weave right back into customer service, you would see veteran satisfaction go through the roof when it comes to seeking care in the VA system. So to address this, we need to recruit and retain the best healthcare providers to care for our veterans within the system. And we need to take advantage of every available option for our veterans outside the system. Now, I want to be clear. I do not believe that full-scale privatization of the VA is a tenable option. But having a VA that concentrates on the areas where it has a critical repository of expertise, taking care of our polytrauma casualties for our most seriously wounded veterans, prosthetics, treatment for traumatic brain injuries and post-traumatic stress would appear to make sense at a time of increasing patient volume and fiscal pressures. To that end, there are a number of policy prescriptions we should pursue moving forward to achieve these goals. First, we need VA positions to be competitive with private sector healthcare employment for both providers and administrators. Congress must embrace the Secretary's proposal to remove the 80-hour pay period requirement for medical professionals within the VA and support increased flexibility in pay scales. Now, I live in Las Vegas, Nevada. We've got a relatively brand new VA medical center. We cannot hire the specialty physicians necessary to care for our veteran population into the VA because you're not going to attract an orthopedic surgeon who's making 7 figures a year in the community to come work at the VA. Not that I'm saying the VA should offer a 7-figure salary to an orthopedist, but there needs to be some flexibility in order to be able to get those community providers to think about coming and working at the VA. It's one of the issues that we face specifically in the Southwest, where we are consistently having to send veterans out of a brand new facility to other states to receive specialty care. So, I think the other thing that we need to look at is one provision that's within Senate Bill 2921 that's called the Veterans First Act, which calls for physicians' assistants specifically that are employed by the Department of Veterans Affairs to receive competitive pay relative to their private sector peers. Another important provision within that bill is the extension of the period for increases in graduate medical education residency slots. Remember back a couple years ago, the number of slots were increased by 1,500. That's set to phase out in 2019. This would continue them out to 2024. The more that we can expose residents to VA healthcare system, the more likely we are to get some of those residents to come back and want to participate as a VA provider. So whether it's the physician, whether it's a nurse, whether it's a PA, whether it's a health system executive, we have to be competitive, and the only way to do that is to give the VA the flexibility to get outside the standard GS or SCS pay tables. Otherwise, we will not be able to recruit someone like the director of Cleveland Clinic Systems or the Mayo Systems into the Veterans Administration. Next, we need to employ those who are most uniquely qualified to care for our veterans, and that's other veterans. One of the issues that I've worked on with Congresswoman Annie Custer from New Hampshire was a bill called the Grow Your Own Directive, Physician Assistant Employment and Education Act. This would actually set up a program where active duty corpsmen or medics would have the opportunity to be trained up to a PA at no cost to themselves if they agreed to work in the Veterans Administration system. Okay? We have to have an increased reliance on mid-level providers, but again, without competitive pay and benefits, it's hard to get them into the system. So let's groom our own from somebody who's already got a history in military health care. Now, we were able to get that through the Veterans Affairs Committee last year, working to try to get it across the finish line. Unfortunately, I don't believe it'll be done before the end of this Congress in the 114th session, so my hope is it gets reintroduced into the 115th session and we can move this forward. And finally, we need to improve the existing choice program so that it works more efficiently. I've heard firsthand that while well-intentioned, the choice program still has its flaws. Veterans may be told that they cannot get a VA appointment within a 30-day window. And so that makes them eligible to go out into the choice program, and they exercise that option. Then they can't find an appointment out into the community for, let's say, 50 days. But once they exercise the option of going choice, they lose their place in the queue for a VA appointment. And now they are actually waiting a longer period of time to get the appointment in the community than what they would have initially had they just scheduled the appointment within the VA. Part of that is because of a paucity of community providers willing to participate and take Veterans Choice. Part of it is because of the scheduling hassles. Part of it is their fear of reimbursement. And I think that is due, quite honestly, to there being a middleman. The way to help alleviate that is to allow the VA to direct contract with community healthcare providers or healthcare community systems that are willing to take veterans patients, to expedite their scheduling, and to ensure rapid reimbursement so that we can actually get more community providers willing to participate in seeing our veterans. Another issue, and I alluded to this briefly in my own area, is the need to send veterans away from home to get specialty care. Rather than send the veteran into a community, when the community care is available and there's a physician willing to see them, sending them out of their own community is not in their best interest. We all know that somebody heals faster when they're in a familiar environment surrounded by the people they love. Sending someone out of state with limited family support is not in their best interest, all because we want to try to keep that dollar within the VA system. So instead of sending them out into the community, we'll send them, like in my case in Las Vegas, they'll send them to Loma Linda, they'll send them to Salt Lake, because they want to keep the dollar in the system. I think we need to put the veteran first. And even if that means that dollar has to flow out of the system to a community health care provider, ultimately, we're going to reap the benefits by having the veteran cared for closer to home in a more familiar environment. So as I mentioned, the choice of community care problems can be partially corrected by allowing the VA to direct contract. This would help also with ensuring that medical records from a community appointment get back to the VA, because now the VA will have a bit of a hammer. If you don't provide the record, you're not going to get reimbursed. Because that was one of the other issues I heard from many of the VA healthcare providers that I've worked with is, look, you want to send somebody out into the community for healthcare, how do we know what was done? How do we ensure we get the record back for continuity of care for everything else that happens within the VA system? I mentioned the Veterans Integrated Service Networks, the visions, and trying to keep people within the vision. I understand the need for regionalization and for a manageable span of control but in states that are big geographically with small pockets of population, these artificial boundaries really stand as obstacles to providing the veteran with more of a voice and more of a choice with where they receive their health care. Again, I'm Nevada-centric. With the reorging of the VISNs just recently, the dividing line is actually across the middle of the state of Nevada. So if you're in the northern part of Nevada, you're going off to Utah. If you're in the bottom part of Nevada, you're going off to Southern California. It doesn't work that way in Nevada. We need to be able to empower the veterans to have more of a voice, more of a choice. So now I'm going to turn to military health care. As mentioned, as many of you know, there are numerous healthcare-related provisions contained within this year's National Defense Authorization Act. I'm not going to go into too many specifics, but rather I'm going to lay out what we said as a starting point within the Military Personnel Subcommittee in the House. Those initial principles are, I think, a roadmap for how we can strengthen the military healthcare system of the future. Real progress will obviously take time, as it always does, but any reform provisions or efforts must be undertaken with two key provisions in mind. First, ensuring that we have trained and ready healthcare providers to support the readiness of the joint force. And second, ensuring we provide a quality health care benefit valued by its beneficiaries. Now, General Ediger mentioned the concerns over the ever-increasing piece of the pie that military health care is taking out of DoD's budget. I've always said on my subcommittee perch, I really don't care. You know, the goal is to take care of the man or woman in uniform. For me, it's not about procurement and acquisition. I don't care if we have the latest, greatest, next generation weapon system, because if we don't have that man or woman to drive it, fly it, sight it, and pull a trigger, then it really doesn't make a difference how great your weapon system is. And while there is cost savings to be had, our approach when we tackled these issues in the subcommittee, it was not from it being a budget drill. It was about how do we make the system better? How do we make sure our providers are ready? How do we make sure we take care of the beneficiaries? And in so doing, if there was a cost savings, great. But it wasn't the principal driver of how we went about the task of looking to reform the military health care system. The ultimate goal, as everybody's heard over and over again, is we want to have a medically ready force and a ready medical force. All of the specifics I'm going to discuss have one or both of those two items, beneficiary care, healthcare provider readiness at their core, and there are 6 focus areas that we concentrated on. Now, I'll preface the discussion with the belief that this will require a formidable education component that emphasizes that military health care's primary mission is readiness. The primary mission of military health care is readiness. And beneficiary care is one of the ways to achieve readiness, but not an ends unto itself. And for a lot of people, it's hard to wrap their brains around the idea that the whole reason that a military health care system exists is to maintain provider readiness and troop readiness. And one of the ways we do that is by providing beneficiary care. First, and I believe most importantly, we must strengthen and maintain readiness among military health care professionals. And there are a couple of things we should do in the near future to achieve that. First is to clearly define how we will determine or measure provider and system readiness. A lot easier said than done. How many of what type of provider with which skills located where are necessary? Not to provide beneficiary care, but to fulfill the military mission. That analysis should drive the number and type of providers in uniform. Second, we need to determine the best way to keep their skills finely honed. You know, as was mentioned, 15 years of war, we've seen incredible strides made in the ability for us to provide far-forward combat casualty care. How do we maintain those skills as we transition from one conflict and prepare for the next? If we intend to use our military treatment facilities as platforms to maintain provider readiness, we need to increase training and complexity of care opportunities by concentrating military provider resources, especially specialty care, at MTFs in locations with high volumes of active duty members, families, and retirees. Then we must provide an adequate volume and mix of cases. In order to do that, we must improve access in care for beneficiaries so that the MTF is their health care venue of choice. Our goal, as we discussed this in the committee, was we need to figure out a way to get more of those who are seeking care in the community or in the private sector, but that are eligible for MTF care, back into the MTF to increase volume, increase diversity, and increase complexity of care that our military health care providers are seeing. This includes extending military treatment facility hours, especially in primary care clinics, beyond the standard operating hours to more align with what the working beneficiary population is used to in the private sector. Increasing access to urgent care when primary care clinics aren't available. And expanding public-private partnerships to increase and complement military treatment facility services provided to beneficiaries. We should require military medical centers to become trauma centers. You know, part of what the NDAA does is reorgs military treatment facilities into 3 broad categories: medical centers, smaller bedded hospitals, and ambulatory care centers. those medical centers should all become level 1, level 2 trauma centers, integrated into the civilian community, to allow the entire trauma team within the MTF to be able to train and maintain their trauma skills. We've seen the success that that's had at the San Antonio Military Medical Center. We should also form additional partnerships to enable not just the surgeon, but the entire trauma team to work in civilian trauma centers for sustained periods of training. There's a great example in my hometown. We were talking about it with General Ediger, how Air Force trauma surgeons rotate through University Medical Center, the only level 1 trauma center in the state of Nevada, one of only 2 freestanding trauma centers in the country. But you know what? While that helps the trauma surgeon maintain their skills, it does nothing for the trauma nurse, for the tech, for the x-ray specialist, for every other piece of that trauma team that needs to maintain their skills as well. So we need to be able to figure out how we keep the whole team trained up and not just the traumatologist or the general surgeon who's trying to maintain his trauma skills for a deployment. And third, just like I mentioned when discussing the Veterans Administration, I believe we must improve the beneficiary's experience at military treatment facilities. And all that really means is that the military health system needs to embrace some of the new technologies and customer service techniques that are already having success in limited application across our healthcare system. Some of those things are providing consistent and predictable patient experiences across MTFs through standardization of appointment scheduling, establishing first call resolution when contacting clinics, increasing the number of available appointments, maximizing the use of things like telehealth and secure messaging. Fourth, we need to simplify TRICARE coverage. The way we're looking at doing that in NDAA is taking the multiple plans within TRICARE and condensing it down just to 2 plans, an HMO version and a non-referral PPO fee-for-service network with predictable fixed cost copays to allow our beneficiaries to actually know in advance how much a visit's going to cost them. Fifth, we need to ensure our beneficiaries receive the highest quality of care. This could be achieved through a number of initiatives, but 2 that I feel really have merit. One is adopting standardized core quality metrics, something that's already in progress through the Military Health System Executive Review, so that beneficiaries can compare performance across organizations. And secondly, incorporating value-based purchasing strategies in the TRICARE contracts to ensure that DoD is paying for quality and not just quantity of health care delivered. Sixth, because the system is so vast and cares for so many, we should look to a centralized management structure. And of all the things that we propose and that were included within the NDAA, I think this becomes one, if not the most controversial. You know, the Military Compensation and Retirement Modernization Commission recommended the formation of a Joint Readiness Command with a subordinate Joint Medical Command. Now, Congress over the years has previously tried to form up a Joint Medical Command. Usually it was a provision tucked into the House version of the NDAA that got stripped out by the Senate when it went over to the Senate and never made it across the finish line. But with the Micromix recommendation, there was a new and renewed focus on whether or not a functional medical command that was truly joint would have merit. Well, we started going down that path and realized that at the same time there were conversations taking place in the Pentagon about 20 to 25% headquarter reductions. There was even some discussions about potentially combining combatant commands. And so we thought the idea of standing up another combatant command was probably going to be a non-starter. In fact, the whole Joint Readiness Command proposal sounded an awful lot like re-standing up Joint Forces Command. And so we thought, if we're not going to be able to stand up a military combatant command, a functional command to spearhead this centralization of management functions within the healthcare community, where do we go? So with its effort to centrally manage shared services and with its experience in managing the MTFs within the National Capital Region, the Defense Health Agency seemed like a logical choice. One idea that was proposed that I think will go a long way towards raising the bar at DHA is creating a C-suite for central management of military treatment facilities within DHA. I mean, for all practical purposes, the Defense Health Agency is a massive corporation, and it should be run as such, with responsibility for MTF management across the enterprise. A C-suite of healthcare professionals and individuals with a background in healthcare facility management will ensure we are meeting standardized care and customer service metrics across the entire enterprise. So those 6 items, strengthening the readiness of military healthcare professionals, increasing access to care, improving the experience at military treatment facilities, simplifying TRICARE, and focusing on quality of care instead of quantity of care, and expanding the role of DHA, whether advanced individually or as a package of a larger package of legislation, will help bring our military healthcare system into the 21st century. Now, I take heart in the fact that many of the people in this room are in a position to help advance many of these proposals. This group is uniquely positioned to be the tip of the spear in bringing these and so many other laudable options to fruition. And always, always with the goal of improving access to and quality of care for our military members and their families. As I said at the outset, great honor to be here today to address this organization. Knowing of your commitment, dedication, and professionalism, I have no doubt that all of us, in our own ways, will raise the bar to ensure we better care for our service members, their families, our veterans, and survivors. I look forward to working with you all in the future, which each of you the very best. Enjoy the rest of the conference. And AMSUS, I thank you for the opportunity to be here.
So much. That was great. Thank you, Congressman Heck. As you spoke about these complex issues, I had a visual of you with your congressman's hat on, the military hat on, and the doctor's stethoscope hanging around your neck as those big influences in your life came together as you framed these very complex and intertwined issues. So thank you so much for kicking this meeting off with what I think is an absolutely perfect tone. 2 more members of the official party have arrived. I believe I see Dr. Trent Adams over here, Rear Admiral Trent Adams, Deputy Surgeon General of the U.S. Public Health Service, and Vice Admiral Raquel Bono. They were both mugged by Washington traffic this morning. Admiral Bono made it to the stage. Admiral Trent Adams didn't, but I wanted to make sure that we recognize their presence here. Thank you for coming. One other recognition before we break. We, AMSUS, have really been proud of the relationship and with the international delegates that have been growing over the years and been such an important contribution to every facet of this program, from the academic content to the networking, to simply the opportunity to meet our international colleagues. So with the international delegates, please stand and be recognized. Just for a moment. We're going to stand in a minute anyway. Thank you so much for being here. We appreciate it, and we'll be giving further and more individual recognition by many at the awards banquet. This concludes our opening ceremonies. If you wait for a moment for the official party to depart, we are going to lead down to the exhibit hall, which now opens. We'll have a brief ribbon cutting ceremony, and then the exhibit hall will be open. Please come take a look at the exhibit hall. The way we handle the exhibit hall is different from most meetings. We don't leave it open for people to just wander down there if they've got a short break in the day, but we open it up at very specific times during which we don't have competing events. That would be right now. So these exhibitors are bringing their best products and their newest developments. They have some wonderful displays. They're very interesting. The book signing is down there. The AMSUS lounge is down there. The Air Force demonstrations are all in the exhibit hall. come down, meet the exhibitors. You'll not only enjoy yourself, there's something for everybody, and we'll all learn something. So if I can get another round of applause for Dr. Congressman General Heck, his opening presentation, then we will depart with the official party. Thank you all very much. Come down this way? Okay.
So the Admiral and I have a great relationship. He talks, and then I come up and say, well, what the Admiral meant to say. We are absolutely ahead of schedule, but so we can all kind of take about 5-10 minutes or so, and then for those that didn't get a chance to get through registration, get through. But then please join us. We will have all the crew there for the ribbon cutting. It's a ceremonial thing we've done for years and years, and we'd like to see you all at the exhibit hall. So about 5 minutes, take your time, but come on down to the exhibit floor.